Now isoflurane is a halogenated gas produced dose-dependent hypotension predominantly from relaxation of systemic vasculature. Hypertension can be treated with direct-acting vasoconstrictor, which is phenylephrine. It undergoes little metabolism and it is considered non-toxic to liver and kidney and has pungent other high blood solubility than others. Desflurane is very rapid onset recovery due to low blood solubility and it is used for short procedures, low volatile, but its higher cost is a drawback. Sevoflurane, it has low pungency and or respiratory irritation. Inhalation induction it is used in with pediatric patients who do not tolerate IV. Rapid onset recovery due to low blood solubility, may be nephrotoxic but with very fresh gas or longer time. Now nitrous oxide, this is important, is a non-irritating. It causes general anesthesia, frequently used at concentration of 30 to 50% in combination with oxygen, and nitrous oxide can be combined with other agents also which will lower the required concentration for this gas. It is poorly soluble in the blood and other tissues. This can be problematic in close okay. It replaces nitrous oxide. Now see, it replaces nitrogen in various air spaces faster than nitrogen leaves. Its speed of movement allows nitrous oxide to retard oxygen uptake during recovery, thereby it causes diffusion hypoxia. Now these are the overall, you can see here: isoflurane, desflurane, sevoflurane. Cardiac output, it is all three same, decrease minimally. Blood pressure, same. For respiratory, initial stimulation is there, but here it is inhibited. For hepatic, low risk, low risk, low risk. For renal, low risk, but some risk for sevoflurane. Now malignant hyperthermia. In very small percentage of susceptible patients, exposure to halogenated hydrocarbons or succinylcholine will produce malignant hypothermia. It is a life-threatening condition, but uncontrolled increase in skeletal muscle oxidative metabolism. What happens is the body's capacity to supply oxygen and remove carbon dioxide and regulate temperature, eventually leading to circulatory collapse and death if not treated immediately. Now you can see this malignant hyperthermia is due to an excitation and contraction coupling defect. Burn victims and individuals with muscle dystrophy, myopathy, myotonia, osteogenesis imperfecta are susceptible. So this is an autosomal disorder. Patient exhibit MH. Dantrolene is given as anesthetic mixture is withdrawn. Dantrolene blocks calcium from the cytoplasmic reticulum and reducing heat production, relaxing muscles. In addition, patient will be monitored and supported for all other symptoms. Now IV anesthetics, they are rapid, often occurring 1 minute or less, most common way. It is also not total IV anesthetics. TIVA. First, induction, the percentage of the drug binds to plasma protein and the rest remain unbound or free. It depends on lipid solubility and ionization. The majority of carbon monoxide flows to the brain, liver and kidney, vessel-rich organs, and GABA plays the large role in IV anesthetics. Recovery from IV is due to redistribution from the CNS and vessel-rich tissues with non-ionized molecules. Now, effect of cardiac output on IV anesthetic. When cardiac output is reduced, the body compensates by diverting more cardiac output to the cerebral circulation. Greater proportion of IV anesthetic enters the cerebral circulation under these circumstances. The slow titration of a reduced dose of an IV anesthetic is safe induction with reduced cardiac output. You have to remember this: slow titration and reduced dose for IV. Now the first